Hello, this is a video presentation of a peritoneal dialysis catheter care plan. After completing the video, the learner will be able to identify the types of PD catheters, identify the rationale for use and the material used in a swan neck PD catheter, discuss the advantages and disadvantages of a swan neck PD catheter, demonstrate pre-insertion preparation of a PD catheter, demonstrate pre-operative and post-operative care of a PD patient, explain ways to maintain short-term care and long-term care of the exit site, and discuss the peritoneal dialysis patient's point of view. There are several types of PD catheters. We have the straight Tankoff catheter, the curled Tankoff catheter, the swan neck catheter, and the Toronto Western catheter. In this video, we will be focusing our attention on the swan neck catheter. So why have I chosen the swan neck PD catheter? With the two downward pointing segments, migration of this type of catheter is rare, and that serves to aid outflow during dialysis. It is also thought to prevent infections at the exit site, as this segment of the catheter also points downwards, thus preventing accumulation of pus and sweat. The swan neck PD catheter is made of extremely kink-resistant silicone for the patient's comfort. It has an inverted U-shaped arc and a downward exit and a permanent pre-formed 150 to 180 degree bend. You see a picture here of a pediatric and an adult swan neck PD catheter. Advantages of the swan neck catheter. The downward exit, double cuff, short sinus prevents exit or tunnel infection. The permanent bend between cuffs prevents external cuff extrusion. The downward intraperitoneal entrance prevents tip migration, and the coiled intraperitoneal tip of the coiled type of swan neck catheter on the picture below prevents infusion or pressure pain. Some disadvantages of the swan neck catheter include possibly lower dialysis solution flow because of the increased catheter length, the possibility of catheter disconnection in the tunnel, and sometimes even tip migration. As PD nurses, it is our role to educate our patients, making them aware of their health condition and everything revolving their treatment. This includes medication, the normal functions of the kidney, CAPD and APD procedures, whichever the patient prefers, catheter and catheter exit site care, which we will further discuss later on, how peritoneal dialysis works, diet that suits them best and what is healthy, infections and how to prevent them, fluid balance, fertility and sexuality, and even ordering and delivery of PD supplies. Before the insertion of the PD catheter, a full preoperative assessment must be done to identify existing or potential hernias that might possibly need correction before PD insertion. Ask the patient what site they prefer to promote participation and to help them understand this type of therapy. Get to know the patient's lifestyle, work, and hobbies when placing the catheter to help them make informed decisions that will best suit their way of life. The exit site should be determined while the patient is in a relaxed sitting or standing position. The site should either be above or below the belt line, whichever the patient prefers. Please avoid skin folds or abdominal scars. The catheter exit site should be located where the patient can effectively carry out exit site care, so within their reach. It will then be marked with a permanent skin marker. On the morning of the operation, the patient should bathe or have a shower. His or her abdominal hair should be clipped. Prevent tension by preventing constipation through a high-fiber diet. The doctor may also prescribe a stool softener or laxative. The bladder must also be emptied before insertion. Perioperative care also includes Staphylococcus aureus screening, administering prophylactic antibiotics, and preparing this patient psychologically. So take some time to get to know the patient, hear out their concerns, and be with them. Taking good care of the PD catheter and the skin around it, as we call it the exit site, is the most important way to keep the catheter working well and to lower the chance for infection. Adequate training and support must be provided by the nursing team upon discharge. The goals of post-operative care is to minimize any bacterial colonization of the exit site and tunnel during the early healing period, prevent trauma to the exit site through immobilization, and to minimize intra-abdominal pressure to prevent leakage. Post-operative care. Directly following the insertion of the catheter, it may be flushed with about 500 to 1500 ml of PD fluid to check patency. Exit site should be undisturbed for about 7 to 10 days following insertion of the catheter, and the catheter tubing must be immobilized by securely taping it to the patient's abdomen. A sterile gauze bandage is usually taped over the exit site to keep it clean and dry. Peritoneal dialysis should ideally be started once the exit site has healed and there is tissue ingrowth into the diaphragm cuffs. Catheter and catheter exit site care can be taught to the patient on a one-to-one basis. So here are two pictures that show the difference between a healthy and an infected exit site. The picture on the right shows drainage, redness, and some swelling, which may be some signs of infection. Short-term care of the exit site. After the first 2 weeks, the skin around the catheter should not be red or painful, and the skin should feel soft. A crust or scab may form every few days, so please remind the patient not to pick on these. The exit site should be kept dry and must not be soaked during this time. Proper cleaning technique should also be done. Remind the patient not to do heavy exercising or heavy lifting, and constipation prevention is also very important. Long-term care of the exit site. Keep the site clear of exudate or debris. Assess your exit site. Before cleaning the area, always wash your hands with soap and water and put on a pair of clean gloves. You may also want to wear a mask. Do not pick or remove crusts or scabs at the exit site. Follow protocols of the institution, for example, cleaning with soap and water, then rinse with sterile water or saline solution, or cleaning with povidone iodine, then pat dry with clean cloth. Antibiotic cream may also be applied. Secure the PD catheter to the abdomen. Swimming and bathing can be discussed with the patients once the exit site is fully healed and ideally free from infection. Sometimes a waterproof or occlusive dressing can be applied, and diving should absolutely be avoided because this adds tension to the abdomen. Now remember how we want to emphasize patient-centered care. Some patients struggle to assume responsibility for their own care and loss of control over their own lives. Care should be focused on the patient's specific needs, so we want to address the language barrier to promote patient involvement in care and clear understanding. Involve their caregivers. Emphasize aseptic technique and catheter care to prevent infection. And of course, be the patient's support system and source of encouragement as patients express their fears and concerns regarding body image changes. Now that concludes this video presentation. Here are the references from which the content of this video was based on. Thank you for watching this video. I hope you learned something new.